Hello. So for the next 15 to 20 minutes, I'll be talking on diabetes game changer, the world first GLP-1 RA in a pill. All of us know GLP-1 RA is a panacea for diabetes. It acts through multiple pathways, it acts on multiple organs, and has multiple pleiotropic effects, and therefore it results in a panoply of beneficial actions. It produces good glycemic control with minimal or no hypoglycemia, improves the cardiometabolic profile of the individual by decreasing weight and blood pressure, provides protection against ASCVD, decreases MI, decreases stroke, and also decreases NFLD and NASH. But its availability only in an injectable form precludes its widespread use. But all of us know medicine is essentially a resolution of uncertainty, and this has been time and again proven on several occasions. And the current breaking news is that GLP-1 RA peptide is now available in a pill. An oral semaglutide is the first ever peptide available in a pill. It has already been launched in 6 countries across the globe, and in India, it is going to be launched in near future, and we are keenly awaiting that day to rejoice this unique innovation. Novo Nordisk has been responsible for several innovations in diabetes care. In 2016, it laid the first foundation stone after the leader trial with liraglutide, and this has shown cardiovascular benefits. In 2019, again, it laid the first foundation stone for oral semaglutide after the Pioneer 6 trial, and the drug was approved for diabetes care. Oral semaglutide is poised to be a game changer in India because of a panoply of reasons. Firstly, all of us know diabetes occurs in India a decade earlier. Cardiovascular disease in diabetes again occurs a decade earlier, and particularly coronary artery disease runs a malignant progressions with increase in morbidity and mortality, increased revascularization rates, and many other features. Uncontrolled hyperglycemia in India is rampant because of high carbohydrate diet by the Indians, and obesity is progressively increasing, and now the kids are also getting affected by obesity. But what was the problem that the peptide in a pill, there were so much challenges. There were 3 big hurdles. All of them have been solved very adequately. The first hurdle in oral semaglutide was that when semaglutide is taken orally, there is degradation in the stomach because of low pH and proteolytic enzymes. The second hurdle was that it has a very limited permeability across the gastrointestinal epithelium. And the third hurdle was that the bioavailability of semaglutide orally was very poor, almost to the tune of less than 0.01%. So the absorption was very limited, but these issues have been resolved by co-formulation with SNAC. All of us know semaglutide is the most effective GLP-1 tested to date and has a very long half-life of 1 week. But when SNAC is combined with semaglutide, SNAC causes a local increase in pH leading to higher solubility and protection from the proteolytic enzymes. It promotes absorption across the gastric epithelium and enhances the bioavailability of oral semaglutide. So when SNAC is co-formulated with semaglutide, this results in oral semaglutide. And when we take oral semaglutide orally, this is the result. The tablet which you take is absorbed through the gastric epithelium and reaches blood, as you can see here. What is very striking is that the exposure-response relationship is similar for oral and subcutaneous semaglutide, as you can see in this slide. So whether oral semaglutide is taken orally or injectably, the blood levels are nearly same, and therefore it is speculated that it will reproduce the CV effects of injectable semaglutide also. Now, why oral semaglutide is going to be a game-changing innovation? All of us know the patients are reluctant to take injectable therapy, whether it is once daily or once weekly. Oral administration is the preferred mode of therapy by the patient. And when oral semaglutide becomes available, it would increase the patient convenience, and this would immensely increase patients' compliance and adherence. And all of us know the innovative oral semaglutide provides efficacy and safety in an oral tablet of the injectable semaglutide, because semaglutide has a 94% homology with human one, GLP, and oral semaglutide is a daily GLP-1 RA co-formulated with snack 300 milligrams. Now, what are these game-changing efficacies of oral semaglutide? We'll see what it does to the HbA1c, which is very important for glycemic control, what it does to reduction in weight. Now, the Pioneer Phase 3A program has several trials, as you can see. So, oral semaglutide has been extensively studied in various comparators and even against a placebo, as you can see in a Pioneer 1. Pioneer 2 it is versus SGLT2I, Pioneer 3 DPP4 inhibitors, Pioneer 5 versus GLP-1 RA oblique placebo, and Pioneer 7 flexible dose adjustment versus DPP4 with extension, and Pioneer 8 is add-on to insulin, Pioneer 5 is renal impairment, and Pioneer 6 was already released 2019. We have Japanese data trials ongoing. Pioneer 9 is Japanese patients versus liraglutide and placebo, and Pioneer 10 is Japanese patient GLP versus GLP-1 dulaglutide, and the SOUL trial is ongoing. Now, if we look at the change in HbA1c at the end of treatment, these are the Pioneer 1, 2, 3, 4, 5, 7, 8, 9, 10. What is the result? Across the Pioneer trials, oral semaglutide provides HbA1c reduction to the tune of 1.5%. When we look at the distribution by race, what is very striking is that the Asians, the red line, the red squares, the Asians have a better HbA1c reduction with oral semaglutide. And when we have HbA1c greater than 9, you can see the results across the Pioneer trials. Oral semaglutide provides unsurpassed HbA1c reduction to the tune of 2.6% in diabetics with baseline HbA1c greater than 9. And what will happen? What percentage of patients which reach HbA1c goal of less than 7? Across the Pioneer trials, 70% of patients reach the goal of HbA1c less than 7. And what you must also understand is that GLP-1 RA, oral or injectable, targets the ominous octet and decreases blood glucose by a disease-modifying approach. As you can see here in the green, 6 out of 8 components are favorably affected by oral semaglutide or the semaglutide. And what is also important that when we look at the quality of glycemic control with GLP-1 RA, it is quite close to the strategy of perfect glycemic control. As you see, it affects the fasting plasma glucose, the postprandial plasma glucose, the short glycemic variability, the long glycemic variability, and the time in range. And on top of this, hypoglycemia is minimal or absent. And even if it occurs, particularly when it's used in conjunction with sulfonylurea insulin, the recovery from hypoglycemia is quite rapid. So it provides a near perfect management of glycemic control. And when we look at the reduction in weight in diabetic, as was already pointed out, is adversely affects diabetic patients and cardiovascular disease. Semaglutide decreases weight in 2 ways. It acts on the satiety center in the brain. It slows the gastric emptying. And what is very important is that the weight loss with oral semaglutide is due to removal of visceral fat, and there's also decrease in the waist circumference, unlike SGLT2, where weight reduction is predominantly due to loss of water and sodium. So across the Pioneer trial, the weight reduction was almost to the tune of 5 kgs. So when we look at the glycemic control plus weight response, you can see oral semaglutide enables high number of patients to achieve both the weight loss as well as the HbA1c reduction. And when we look at the necessity of other drugs to have a better glycemic control, you can see oral semaglutide was more effective than SGLT2 inhibitors, and oral semaglutide is more effective than even injectable liraglutide, and it was more effective than DPP4 inhibitors. What is the game change in the safety of semaglutide? Now, semaglutide is a very safe molecule. Only gastrointestinal side effects are the problems which are seen in small number of patients. And if due precautions are taken, they can be minimized to a great extent. Up to 80 to 85% of subjects treated with oral semaglutide did not experience any nausea. You have to educate the patient when you are prescribing semaglutide, make the patient aware of the possible GI effects, suggest mitigating measures such as diet modifications, and patient should seek medical advice in the event of a GI symptoms. When we look at the hypoglycemia, this is minimal with oral semaglutide. It's only seen when you use it with insulin or sulfonylureas, and this can be minimized by decreasing the dose of both these agents. Pancreatitis is very, very rare, but if there's a history of pancreatitis in past, this drug should be avoided. And caution should be exercised with history of pancreatitis. Diabetic retinopathy, again, if the patient has diabetic retinopathy, the incidence is little more, has been reported with the SUSTAIN 6 trials, and was believed to lead to rapid fall in the HbA1c. So caution must be exercised. These patients should be monitored closely and treated according to the clinical guidelines, and a rapid improvement in glucose control should be avoided, because that is supposed to be one of the factors. But other mechanisms cannot be excluded, and a dedicated trial of oral semaglutide is ongoing in diabetic retinopathy, and there we will be able to have a clear answer. So when we look at the summary of the Pioneer program, tolerability is consistent with GLP-1 RA class. Mild to moderate or transient GI symptoms are the most common side effects. The adverse effects are very less, and overall incidence of adverse effects and serious events were similar for oral semaglutide when compared with EMPA, SITA, and LIRA. What about the cardiovascular events? The Pioneer 6 trial was already released in 2019. This was a safety trial, but within a short period of 16 to 17 months, it showed a 21% reduction in cardiovascular death, MI, and stroke. And there was a great reduction in cardiovascular mortality and all-cause mortality, almost to the tune of 50%. And the SUSTAIN 6, all of us know, also shows injectable semaglutide, a positive result, a significant reduction in the primary endpoint, 26%, and with great reductions in stroke. When we club both these trials, again, you can see semaglutide or oral semaglutide, there's a 26% reduction in the cardiovascular events. It also has a favorable effect on the lipid metabolism. As you can see here, the triglycerides levels are decreased, the VLD levels are decreased, no significant difference in the fasting free fatty acids, and the ApoB levels are also decreased. The total cholesterol is decreased, the LDL is decreased, the triglycerides is decreased, HDL, there's no significant change. There are certain precautions which have to be adopted by the patient when you are taking oral semaglutide. It has to be taken on an empty stomach, and he should take it with half a glass of water or 120 ml. And for the next 30 minutes, nothing should be taken by mouth, and after 30 minutes, he can take the drug. The drug has to be started in smaller doses to avoid GI toxicity. 3 milligram for 1 month, you can step up by 7 milligram after 30 days, And again, after 30 days, you can step up by 14 milligrams. Now, what is the game change in the convenience? This is the CV outcome SOUL trial, which is ongoing, and we are keenly awaiting the results of SOUL trial. The drug interactions are minimal. Usually, there is some interactions with the thyroid hormone, and warfarin exposure is not expected to any great extent, but one can monitor INR to see. So the advantages of oral semaglutide is there's no dosage adjustment in terms of renal or hepatic impairment. Elderly patient, again, no dosage adjustment, and hypoglycemia, we already talked, is minimal. So when we look at the overall summary of the oral semaglutide, this is more effective than EMPA and SITA in terms of reduction in HbA1c, is non-inferior. It's comparative to liraglutide. Weight reduction, again, it is oral semaglutide is superior to SITA, lira, and EMPA. And oral semaglutide has demonstrated significant greater HbA1c and weight reduction. And the Pioneer 6 was a cardiovascular safety trial, which has already been released, and are waiting for the SOUL trial. Oral semaglutide was well tolerated, and the side effects are rare, and it is inefficacious. So in summary, GLP-1 all of us know, are a panacea for treatment of diabetes over the past 2 decades, but their availability in an injectable form has precluded their widespread use. But now we have this great molecule, oral semaglutide, which is poised to be a game-changing innovation, allowing for the first time the efficacy and safety of GLP-1 with convenience in an oral tablet form. Oral semaglutide has demonstrated significant greater HbA1c reduction and weight reduction compared to placebo and the comparators, and the efficacy has been established in all stages of disease, late as well as early, in renal as well as hepatic impairment, and oral semaglutide is well tolerated with a safety profile which is consistent with the GLP-1 class. Thank you very much for your kind attention.
So, have you used GLP-1 receptor analogs?
Yes, we are using it quite frequently, and especially post-MI with diabetes, diabetes with obesity. These are the common patient subsets where we are using it.
Okay, so can you share some of your clinical experience? Like most of us are more concerned regarding the side effects and counseling of the patient, and how do you go around it?
So overall, side effect wise, it is a very safe drug. So I think whenever I prescribe liraglutide, I always look at 1 or 2 factors. One, previous history of pancreatitis or pancreatic carcinoma, and previous history of thyroid carcinoma. So these are the 2 important things which I look into. If that is not there, if there is no history suggestive of this disease, in that case, you can safely prescribe this particular molecule, liraglutide. You start with a 0.6 milligram dose once daily, and after a couple of weeks, you try to step it up to 1.2 milligram, and then you maintain it on at 1.2 milligram for a long time. And usually, what we have seen is we get a very good HbA1c reduction with this particular molecule. So if we are using it as a monotherapy in real world practice, we are getting around 1 to 1.5% HbA1c reduction. And when you combine with metformin or with other drugs like sulfonylureas, in that case you get HbA1c reduction of almost 2%. And overall the risk of hypoglycemia is very less, close to 0, when you use it as a monotherapy or when you use it with metformin. And you get a very significant weight reduction in this particular molecule. So when you give this particular molecule to a patient who is obese, you get almost like 2 to 3 kilogram reduction in next 3 months or so. And when you have a combination with metformin, you get a higher weight reduction when it is a combination therapy. And this weight reduction also depends on the baseline weight status of that particular individual. Somebody who has a baseline weight of 120 kg will get greater reduction compared to somebody with 90 kg weight.
Right. So the higher the weight, the better is the benefit.
Yes.
Okay. And would you like to give any, do you routinely give any do you routinely give any antiemetics or anything to counteract the symptoms or the side effects of the drug?
Usually we start at a small dose, 0.6 milligram once a day. With that, patient may get some amount of nausea, but overall vomiting is very uncommon. And somebody who has symptoms of nausea, I would give them a proton pump inhibitor as well as domperidone combination for a couple of weeks. Once they keep taking this medicine for more than 2 weeks, then usually the side effect of nausea disappears.
Yeah, so we need a drug which is thing, and domperidone will reduce the will counter effect the actual mechanism of the GLP-1. So ondansetron perhaps would be a better drug. I think Dr. Manoria has a huge practice, and he uses liraglutide very frequently. Maybe sir can add a few points on that.
Usually we start the first 2-3 doses 0.3 milligram. We have seen that if you start with 0.3 milligram and then switch on to 0.6 and later on 1.2 and 1.5, nausea and vomiting are less when compared to using this drug with 0.6 milligram. So our attempt is for the 2 days we use only 0.3 and then switch on to 0.6.
Okay. So you teach them how to use the pen, or the company person educates them about the usage.
Our sister is trained, she injects the drug.
Okay, fine. So, and sir, at what stage in the CV continuum do we usually, want to start this drug?
The compliance is maximum after a myocardial infarction or a stroke. Although we desire to use it for high-risk primary prevention also, but when a patient develops myocardial infarction, the compliance is excellent. He listens to whatever you say. And regarding the hitch of injectable therapy, we usually tell the wife, if you tell the wife, the injection is invariably given. So that is the best way that the compliance for injection is taken care of. If you tell the patient himself, he may not inject. Once the wife is told, this is 100% compliance we have seen. So we educate the wife and tell us that it has to be taken regularly. The compliance is almost 100%.
Yeah. Sir, and hypoglycemia, I'm sure, is not a challenge at all with this.
Hypoglycemia is minimal.
Yeah. So, do you usually with which other anti-diabetic drug do you club it?
Most of the patients when they come to us have CKD, they have heart failure. So our desire is always to use a combination of SGLT2 and GLP-1RA. This may be a problem for some patient, but when the oral form is available, GLP-1, the combination will be very easy. And when we use both these drugs, this provides a comprehensive approach for ASCVD, CKD, and heart failure, and has several other benefits also. So that is our desire when we have a late diabetic patient after many years. Most of them has the comorbidities.
Yes. And also regarding the cost, I very often I find this a bit of a challenge, because our patients are already on so many other drugs, and the additional cost of this is sometimes a hindrance. But we need to educate them that they have to be, either being penny wise now might prove to be pound foolish later on. So I guess we need to educate them for that as well.
I think the issue is not using the drug is more costly than using the drug. If you don't use the drug and patient develop MI, there's no cost can be put for that. So not using the drug is more costly. If he develops MI, it ruins his family. The pre-hospital mortality is 25%. The in-hospital mortality in the best of the center is 3 or 4%. First-year mortality is under 5%. And if he presents late to the hospital, he has a residual LV dysfunction, which creates problem in the long run. The dual antiplatelet therapy, which he's on, also has problems. So if an MI can be prevented, it is very easily. So usually we say not using is more costly than using it. Yes. The MI prevented is a great achievement. Recurrence prevented is a great achievement.
Yeah, rightly said so. So can we start with your talk, sir?
Yes.
So any so and how do you foresee the use? I mean, I have seen a lot of diabetologists also or endocrinologists. Not all of them are really very, aggressively using this drug. So how should we as cardiologists kind of, instill more confidence in the patient to use the drug?
I said the problem of cost once a patient develops MI is usually not there, because once he can afford an angioplasty, he can take this drug if it is properly explained. And we usually explain that not taking a drug is more costly than taking the drug for several reasons. Regarding the injectable therapy, we always brief the wife, and once she is briefed, we have seen that the compliance is almost 100%, because the patient cannot escape from the wife. The injection will be given. And the benefits has to be told that it should not be projected as an anti-diabetic medication. It is a heart attack reducing drug that should be explained. Otherwise, if the drug is projected as an anti-diabetic medication, the patient usually compares with the other drugs which are available, like the sulfonylureas, which are cheap and have a good reduction in the HbA1c. So this should be very carefully explained, that this is a heart attack reducing drug, this is a stroke reducing drug. If you use the drug, there's no hypoglycemia, there's decrease in weight instead of increase in weight in insulins. Frequent monitoring is not required, and it has many other added benefits like reduction in weight, reduction in blood pressure. So it has multiple benefits. Only the patient has to be explained that these are the benefits, and usually I think he agrees to it, particularly after he has an MI.
So I have read that the Asian subset has more effective glycemic control compared to the rest of the world. So is there any specific reason why that could be there? And do you think that with the advent of oral semaglutide, it would be a real game changer?
Indians take a very high carbohydrate diet. That may be one of the reasons, and there may be other reasons. But when we look at this issue which you are asking, from the point of view of glycemic control, this lower dose may be useful, but our aim is not only glycemic control, our aim is also to decrease ASCVD, and there's no data on ASCVD that lower doses 7 or they are effective. So usually would prefer the 14 milligram dose. That is more desirable, because our aim is not only to have a glycemic control, but also to have other effects, particularly improving the cardiometabolic profile, because the decrease in weight is also essential, and we know increase in weight by 3 kg offsets the benefit of reduction of weight, we say, by 1%. So although Asians have shown better data, but it seems that we would desire to have the overall effects and not focus merely on glycemic control.
So with the oral semaglutide data currently from Pioneer 6, how do you look at it in terms of cardiac benefits? Since we need to talk, I guess we need to, you know, drive in the point very strongly regarding the cardiac benefits that will encourage and our patients to take it.
See, the Pioneer 6 trial was carried out with 14 milligram. The SOUL trial is also being carried out with the same dose. The Pioneer trial was basically a safety trial, and within a short period of say 17 or 18 months, it showed a 21% reduction in the cardiovascular death, MI, stroke. And what was very striking that within this short period, the all-cause mortality and the cardiovascular mortality were reduced to the extent of 50%. That was very encouraging. The other thing is because oral semaglutide and injectable semaglutide has shown similar or slightly better with oral semaglutide, the reduction in weight, the reduction in HbA1c, which means that whether you are giving oral semaglutide by oral route or whether you are giving semaglutide by injectable route, the drug is reaching in a similar concentration. That's why it is producing nearly similar effect on the HbA1c reduction and on the weight. So it is likely that it will also replicate the results of the injectable semaglutide, but the final answer will come from the SOUL trial. But these are presumptions which are based on these scientific facts.
Yeah. So I think this is the drug which not only has a good glycemic control, but it is also having significant reduction in atherosclerotic risk. And besides, it has the advantage of, weight reduction as well. So definitely, I think it is going to be a real game changer.
What is also important to remember is that it produces glycemic control by a disease-modifying approach. Unlike sulfonylureas and others or the other drugs, we do not modify the disease. That should be very important. So if initiated early in the course of the disease itself can be modified, the progress can be blunted. And the hypoglycemia is very minimal. This is again a very great advantage. And I showed you the glycemic control is just near a perfect glycemic control because of several reasons. So disease modifying reduction in glycemic control is very, very important.
So Gaurav, any take on that?
Yeah, so as sir very rightly mentioned that it has a multifaceted mechanism of action. It not only reduces HbA1c, but it also has effect on myocardium, effect on vascular level, reduces atherosclerosis, reduces inflammation, reduces body weight, helps in controlling blood pressure, and so there are multiple benefits. And it is not only a drug for diabetes, and now it is being studied even for obesity per se, even in absence of diabetes, whether it can be used in obese patients for weight reduction purpose. So that also is being studied. And we have been part of a select trial at Ruby Hall where we had injectable semaglutide in patients with obesity and cardiovascular disease. So anybody who has had previous MI, stroke, peripheral arterial disease, and along with that overweight or obese. So in this subgroup also we are studying injectable semaglutide. So that will also be very interesting to know whether it will be a drug for non-diabetic obese patients.
Yeah, that's an interesting point actually. So I think most of the points we've covered. Anything else you want to add, sir?
I think the future of oral semaglutide is being tested by several trials. We have the FLOW trial in CKD, we have the FOCUS trial in diabetic retinopathy, which is waiting for the questions to be answered. We have trials in NASH, we have trials in Alzheimer's, we have trials in Parkinson's. So a lot of trials are ongoing with this molecule. And in future, we have a lot of more data on the other comorbidities like CKD and diabetic retinopathy. Both of them are not uncommon in diabetic patients. But the molecule is poised to change diabetes care in our country. where diabetes is rampant, where obesity is rampant, where bad glycemic control is rampant. So it is going to be a game changer in our country.
No doubt, sir. And I think very soon, you know, in our prescription we have already added SGLT2. We will be adding GLP-1 as well.
Yes.
So thank you, Gaurav, and thank you, sir, for a very nice and informative talk and a very good discussion. So I hope you know, all our listeners have also gained some more knowledge and feel more encouraged to use the drug. Because for myself, I can say that definitely now I am really keen to try it out. I have for few patients, but yeah, now I'll be a little more aggressive on that. So thank you, everyone.